We have another excellent speaker with Dr. Nina Tan, who will be talking to us about different topics for women's health, which will touch on a number of different organ systems um, and will be helpful for your boards as well as your clinical practice afterwards.
Hi, everyone. My name is Nina Tan. I am a assistant professor of clinical medicine at the University of Washington. I have my primary care practice at the OB/GYN primary care clinic over at the Roosevelt Clinics at UW. Also practice breast health, benign breast health at UW and Fred Hutch. I'm happy to join you all this year for the board review course. Previously, this has been done by my colleague Addie McClintock and Eliza Sutton, who both have created these slides that we've sort of modified over the years because there's lots of good information here. So here's my email address in case there's any questions. I have nothing to disclose here. Some of the key topics we're going to be going over, we're going to talk about some sort of key screening and prevention recommendations. And then we're also going to talk about pregnancy and health. Even though we don't typically treat patients throughout the entirety of pregnancy, we will see them typically in early pregnancy when they're planning for pregnancy and maybe after they've delivered as well. Evaluation and management of breast lesions, abnormal bleeding, contraception, and menopause. And everything that we're talking about today really applies to those who are assigned female at birth who have, breast tissue, uterus, all of the sort of female anatomy that comes with being assigned female at birth. So to start with screening, we're going to open with a case. We have a 32-year-old woman who has no past medical history and presents for a wellness exam. She's never smoked, rarely drinks alcohol, is sexually active with one monogamous male partner, and uses a levonorgestrel IUD for contraception. She had negative STI screening 2 years ago. Her last cervical cancer screening was at 29, and that was negative cytology with no HPV testing done. And her maternal grandmother had breast cancer at 7 years old. So what screening is advised for today? Okay, great. So 100% here. This is not a difficult question here. We're just thinking through cancer screenings. We're thinking through infectious disease screenings for this patient. So with screening mammography, that is really recommended to start at 40 years old for those who are at average risk of breast cancer. And we'll talk more about how we try to understand what someone's risk is like. GCCT testing, so STI screening, the recommendations here are for women under the age of 24 or who are 25 and older who are at higher risk, unprotected sex, maybe have multiple partners, things like that. And then cervical cancer screening recommendations. At this point, she's 32. Her last cervical cancer screening was under the age of 30. So we can go ahead and do additional screening at this time. After 30 years old, we would do it every 5 years. Using HPV primary screening or co-testing would be sort of the preferred method, as opposed to cytology alone, although that is also an option if for whatever reason the lab that you're at doesn't have an HPV test. And then clinical breast exam, there's really insufficient evidence to suggest that clinical breast exams are beneficial from a cancer detection standpoint, especially when compared to the risk of false positives. So you might have patients, especially who are older, who used to get annual breast exams as part of their wellness visit. This is not something that's recommended anymore for those who are at average risk of breast cancer. So just to sort of, talk about cervical cancer screening here again, for those who are at average risk, meaning they don't have immunocompromising conditions, when to start screening, we would start no later than 25 years old. There's still some discrepancy between the guidelines. So USPSTF and ACOG still says to start at 21 years old, whereas ACS says to start at 25 years old. I don't think this is going to be a question on the boards, but just know that at least at 25, that is when to start cervical cancer screening. There's a couple of different test options available now, and there continue to be new test options available as well. So there are HPV-based testing options. So there's primary HPV testing with reflex cytology, and that is collected every 5 years in the clinic. There's also HPV with cytology co-test, meaning that those two things are run at the same time, as opposed to if HPV is positive, then reflexing to cytology. And that is collected every 5 years also. And then now there's a new option for a self-collected HPV test. I don't know that this is something again that will come up on the boards just because it's relatively newer. However, it has made its way into the USPSTF guidelines already, and so the recommendation there is for repeat screening every 3 to 5 years if the patient is doing their own self-collected sample in the clinic is the recommendation using an FDA-approved test. If you're not sure if your lab has that, you can, talk with lab medicine about that. There are also some direct-to-consumer tests that are out there, but I think right now we're really focusing still on the clinic collected swabs there. And then there's also the option to continue cytology alone every 3 years. This is really falling out of favor. In general, we're trying to switch more towards an HPV-based screening method, just given that most cases of cervical cancer are caused by human papillomavirus infections. And how do we choose which test to proceed with? So again, here's where there are some different guidelines, and I don't think this is going to be an emphasis on the exam, but with USPSTF, they recommend that between the ages of 21 to 29 years old, cytology alone is used, which means that since it's cytology alone, the test is checked every 3 years. After the age of 30, any of these options are okay, again, with an emphasis on HPV-based testing. ACS guidelines recommend any method starting at 25, but really an emphasis on primary HPV testing if possible. And when do we stop screening? So for average risk patients, we want now the last test to be at least at 65 years old or later, and for the testing to have been normal for the past 10 years. And so that means if you're using cytology alone, that at least 3 of those tests have been negative consecutively. And then same with HPV testing, since it's an every 5-year interval, at least 2 of those have been negative. The caveat here is that if there's a history of CIN2 or higher on prior studies, so this patient has a history of cervical dysplasia, we would want to continue with screening for at least 25 years. So depending on when the patient might have had that pathology, we would extend the screening outwards past 65 potentially. The exceptions here, there's a couple of populations that we want to pay a little bit more attention to when we're doing cervical cancer screening. So if there's a history of immunosuppression, so for example, if there's a diagnosis of HIV infection or AIDS, if there's a diagnosis of lupus, or if they are currently taking immunosuppressive medications, for example, history of transplant, they have inflammatory bowel disease or rheumatoid arthritis, multiple sclerosis, etc. We do more sort of aggressive cervical cancer screening. So the recommendation between 21 to 29 is still with cytology, but actually choosing to do annual cytology. And if there have been 3 consecutive negative tests at that point, maybe considering spacing out to every 3 years. And for those who are 30 or older, a co-test rather than HPV-based alone, a co-test is recommended every 3 years. And then the same applies for if we're choosing cytology as the option, then annually, except if it's been negative for a couple of years, then you can space it out to every 3 years. The other population to pay a little bit more attention to here is if there was DES exposure in utero, this is becoming much more less common now, then the recommendation is for annual cytology screening because of that increased risk of clear cell carcinoma, adenocarcinoma that is not caused by the human papillomavirus infection. So, a lower yield to be checking for HPV infection. So just back to the case really quickly to wrap this up. With our 32-year-old woman who had cervical cancer screening when she was 29, which was negative for cytology, no HPV testing at that time, would recommend switching over at this point after the age of 30 to HPV primary testing with reflex cytology. The other options are also acceptable, but this is probably the best answer, HPV primary testing. Next, we have a case for a 42-year-old woman who presents for a wellness exam. Her mother was diagnosed with breast cancer at 67, and her only maternal aunt had ovarian cancer at 71. Her last screening mammogram was 2 years ago and was normal, and she asks when she should have her next mammogram and whether she needs additional breast imaging given her family history. What is the most appropriate next step? Okay, great. So we have most people choosing E with one choosing A. So let's talk through this um, here. So the correct answer is E. The goal here is to assess the patient's breast cancer risk and decide from there whether or not they might need genetic testing and whether or not they actually might need additional screening imaging, given this family history. So some of the major risk factors for breast cancer include a family history of breast or ovarian cancer. For patients who have, for example, mom who had ovarian cancer, that still increases their risk of breast cancer by about 1.5 to 2 times. If there's a personal history of an atypical lesion, so they've already gone through diagnostic imaging, they've had a breast biopsy before, and that showed atypical ductal hyperplasia or atypical lobular hyperplasia of the breast, that is a major risk factor, increases their relative risk of breast cancer by maybe 4 to 6 times. Of course, if there's a known hereditary mutation, BRCA1 and 2 are the most commonly known mutations. However, there are a lot of other mutations that are both high penetrance mutations and moderate penetrance mutations that put people at higher lifetime risk of breast cancer, in which case we would also be recommending more aggressive breast cancer screening. Um, and then if there's a history of chest radiation therapy, especially in childhood or adolescence as the breast tissue was developing, this is another major risk factor, and we should be screening a little bit earlier in life and more aggressively as well. I included some other risk factors just to keep in mind here. They're not going to increase the relative risk of breast cancer as high as the ones that I listed at the top, but they are things that affect risk of breast cancer. So, for example, breast density, prior pregnancy history, especially no prior pregnancies or pregnancy after 30, um, elevated BMI after menopause, sedentary lifestyle, alcohol use, early menarche, late menopause, and hormonal contraception use, all of which can increase estrogen exposure throughout a lifetime, estrogen progesterone exposure. And in terms of thinking about how we manage risk for patients who are at average versus high risk. So for average risk patients, according to USPSTF guidelines now, we are starting screening mammograms at 40 years old and opting for every other year in order to balance cancer detection and the risk of false positives, of anxiety from those things, et cetera. That's a grade B recommendation. And then for those who are at high risk, which is what is considered to be a 20% or greater lifetime risk of breast cancer using a breast cancer risk calculator model, the recommendation there is for annual screening mammograms and annual screening breast MRIs, and that is from both ACS and NCCN National Comprehensive Cancer Network guidelines. An additional thing that I just want to highlight here is that USPSTF also has a grade B recommendation to offer risk-reducing medications for patients who are 35 and older who also fall into this category of being deemed at high risk of developing breast cancer. I don't think this is something that will be tested on, but it's maybe something just to know that there are these risk-reducing medications out there, for example, tamoxifen and some of the aromatase inhibitors and raloxifene. And those can be used to help reduce risk of breast cancer and of course come with their own risks and side effects there. Um, I don't think we'll be asked to calculate the estimated lifetime risk of breast cancer, but the next step of requesting risk stratification is an important one to help make sure that our patients are getting adequately screened for breast cancer. And the last thing to highlight here is that right now there is insufficient evidence to recommend for or against supplemental screening for dense breast tissue, and that comes from the USPSTF guidelines. Of course, again, there are varying guidelines, as with everything in women's health, people have their own opinions. But right now, the sort of prevailing thinking is that there really isn't enough robust, clear evidence to say that we can use one modality of supplemental screening with excellent cancer detection rate that is not also compromising the false positive rate. So next topic we'll start to cover here is abnormal uterine bleeding. We'll spend a little bit more time here as well. Another case, 26-year-old woman who presents with menstrual cycles every 45 to 90 days, has moderate acne and hirsutism, which she finds bothersome. Prior labs showed an elevated free testosterone level and normal TSH, prolactin, and 17-hydroxyprogesterone levels. BMI is 32, fasting glucose is 108. does not desire pregnancy at this time. And in addition to lifestyle modification, which of the following is the most appropriate initial pharmacologic therapy? And the poll is now open. Okay, so a little bit more of a spread here with our results. So majority opting for C, but people choosing any of the others as well. So let's talk through these. Let's talk through these options. So within the stem of this question, of course, this is alluding to the fact that this patient has a diagnosis of formerly known as PCOS, now known as PMOS, polyendocrine metabolic ovarian syndrome. And so now the next step here is how do we typically treat PMOS or PCOS here? So let's start with metformin alone. This can be helpful for some of the comorbidities with PCOS or some of the sequelae of PCOS. For example, it can be helpful for hyperandrogenism, which is evidence with the patient's history of acne, hirsutism. It could also help make periods more regular, but it's not actually really a first-line medication, and especially not when used as monotherapy. I'm sure it can be helpful for insulin resistance as well. But this patient, it sounds like, is desiring contraception and also is bothered by these hyperandrogenic symptoms. And so I would look for a method that's going to help with multiple of those complaints. Another thing to highlight here is metformin does not offer any sort of endometrial protection. One of the things to know about PMOS is that over time, there's a lot of unopposed estrogen exposure, which increases the risk of endometrial hyperplasia and cancer. So we want to provide something that helps to protect the endometrium, especially if they're having less than 4 periods a year. Spironolactone alone is another option for treating specifically acne and hirsutism. I'm sorry, there's a typo here. It does treat hirsutism, but it's not going to be helpful for contraception, which this patient has said that she's interested in. So the answer here is the combined oral contraceptive pill for a couple of reasons. It will help address the hyperandrogenic symptoms. It is a first-line medication for treatment of acne. It will also help with menstrual irregularity and will provide this patient with reliable contraception overall. And just note that this patient doesn't have any contraindications to the use of estrogen and progesterone here. And then lastly, we also have the levonorgestrel IUD. This is a great option for people who are looking for reliable contraception. However, especially in this case, when the patient already has pretty bad acne, which she finds bothersome, I would maybe not use this as first line because unfortunately progesterone IUDs can worsen acne, sort of increase the risk of things like rosacea, and it will not treat hirsutism as well. So a little bit more information about PMOS here. So typical clinical presentation is irregular periods. So whether they're having fewer than 9 periods a year, or maybe they've gone 6 months or something without a period. Sometimes people actually are diagnosed with PCOS or PMOS when they are trying to become pregnant and they find out that they are dealing with infertility. Signs and symptoms of hyperandrogenism, so like I said, acne and hirsutism. And we really want to differentiate this from virilization. So virilization is where there's more extreme changes that are found, for example, clitoromegaly or deepening of the voice. And this is more concerning for an androgen secreting tumor. And if there are those symptoms present, I would make sure that we're including that in our workup as opposed to just focusing on a PMOS workup. And then another thing here is that oftentimes with PMOS, patients are not only at higher risk of developing metabolic syndrome, but might already be presenting with things like MASLD or diabetes, et cetera. So that's something we want to keep in mind in terms of their lifetime cardiovascular risk. Diagnosis, most people are using the Rotterdam criteria to diagnose PMOS. So thinking about oligo or anovulation, so fewer than 9 periods a year. Hyperandrogenism can either be diagnosed clinically with symptoms like acne and hirsutism, or based on lab values, for example, looking at an elevated testosterone level. And then polycystic ovaries on ultrasound are also diagnosed or are also part of the diagnostic criteria, but they are not required for the criteria, and that's why this this whole syndrome has actually been rebranded as polyendocrine metabolic ovarian syndrome. A couple of other considerations here, like I mentioned, there are increased metabolic and cardiovascular disease risks. And so just keep in mind, you might be screening a little bit earlier for things like diabetes, for hyperlipidemia, keeping an eye out for liver enzyme abnormalities as well. Really, huge emphasis on lifestyle modification, especially for people who are dealing with, for example, infertility and also have PCOS. Sometimes if there is even 5% weight loss, if there's weight to be lost, that can actually help with live birth outcomes. And then, as I mentioned earlier, there's also a higher risk of endometrial cancer with a diagnosis of PMOS because of those periods of unopposed estrogen exposure with these sort of chronic oligo or anovulatory cycles that happen. And that risk is relative risk of about 2 to 5. So thinking about these symptoms, this presentation, how do we treat PMOS? So maybe one of the more important things here is thinking about endometrial protection because people are at higher risk of endometrial hyperplasia and cancer, and especially again if they're having very few periods a year. We want to help protect the endometrium, and so using hormonal medications can do this. Combined OCPs is a great option. Hormonal IUD is also a great option. Progestins or progesterone alone, so for example, thinking about a Nexplanon or progesterone-only pills, those can also be helpful overall, but oftentimes they lead to a little bit more abnormal bleeding overall. So adherence to these medications may not be great. Thinking about the androgen excess, as I mentioned earlier, combined OCPs are one of the first-line medications to treat acne, so it's always a good option if patients can tolerate, or it's safe for them to tolerate estrogen. Spironolactone and finasteride are also going to help, especially reduce acne and also hirsutism. And then topical creams like eflornithine or laser therapies, aesthetic treatments, things like that. And then for infertility related to PMOS specifically, as I mentioned earlier, weight loss can be helpful. Metformin, typically when used with other therapies as well. And then other medications that you're going to be referring out to probably won't come up on the boards, but medications like letrozole, which is an aromatase inhibitor, and Clomid as well. Moving on to our next case, a 48-year-old nulliparous woman presents with a 5-month history of heavy vaginal bleeding every 2 to 6 weeks, sometimes lasting up to 2 weeks. She has no history of bleeding disorders. Her BMI is 38. She has hypertension, type 2 diabetes, and a history of PMOS. Pelvic ultrasound shows an endometrial stripe of 10 millimeters. Her last pap smear was normal at 45, so 3 years ago. Which of the following is the most appropriate next step? Okay. So we have most people have chosen C and a couple have chosen B, and C is the right answer here. So the a couple of things to note about this patient. So this patient is not postmenopausal, just to highlight this. However, there are some risk factors for endometrial hyperplasia and endometrial cancer that we should discuss here and make sure that we're working up. So nulliparity, so no sort of breaks from estrogen exposure. The symptoms that she's presenting with this heavy, more frequent bleeding is also more concerning for something like hyperplasia or cancer of the endometrium. BMI is higher. Unfortunately, that is also associated with hyperplasia and cancer. Has a history of type 2 diabetes and a history of PMOS. Each of those is an independent risk factor as well. And then lastly, the objective data that we have here, so her endometrial stripe on the pelvic ultrasound was greater than 4 millimeters. 4 millimeters is the cutoff for a postmenopausal person. So it's a little bit harder to interpret this. So especially if this was someone who was 55 and that they haven't had a period for 3 years and you see this endometrial stripe of 10 millimeters, that's something that I would say should be interpreted as a reason to recommend ruling out endometrial hyperplasia or cancer. The other options here are, are things that aren't really getting at the underlying concern of wanting to make sure that we're ruling out more significant pathology. So the key point here is thinking about when to rule out endometrial cancer if you have a case with abnormal uterine bleeding. So, of course, postmenopausal patients who have any uterine bleeding, this is, number one, two, and three on the differential, as they say, would be endometrial hyperplasia and cancer. We want to make sure that we rule this out with both a pelvic ultrasound and with an endometrial biopsy is becoming the recommendation to actually do both together. And then we're looking at people who are younger than this who have other risk factors. So, for example, patients who are under the age of 45 but have a history of unopposed estrogen. So, they maybe have a history of PMOS, they have a higher BMI, or maybe they have a history of tamoxifen use if they have had prior breast cancer or they were considered to be at high risk of breast cancer. We know that tamoxifen can increase the risk of endometrial pathology like hyperplasia and cancer. And then, of course, if we have a patient for whom they've been taking OCPs and they continue to have heavy irregular bleeding, your medical management has not been effective in treating the abnormal bleeding, then this is where we go back to the drawing board and think about what else could we be missing on the diagnosis here. So this is where another situation where I would have a low threshold to rule out endometrial cancer. And then also for patients who are 45 with bleeding that is newly frequent, heavy, or prolonged. If you look at the guidelines, a lot of them are becoming a little bit more aggressive about this now, that if there is just any sort of abnormal bleeding after the age of 45, we can, have a low threshold to get an ultrasound and again, endometrial biopsy as well here. Thinking about a framework for some of the other causes of abnormal uterine bleeding, we talked about PMOS, we talked about malignancy here. You all might remember from medical school days the PALM coin mnemonic. So PALM stands for polyp, adenomyosis, leiomyoma, which is just another word for fibroids, and malignancy and hyperplasia. And those are the structural causes of abnormal bleeding. On the coin side, we have non-structural causes of abnormal bleeding. So coagulopathies, such as bleeding disorders, about 20% of patients who have heavy menstrual bleeding will. About 20% of patients with a bleeding disorder might present with heavy menstrual bleeding as one of their first symptoms. Ovulatory dysfunction, PMOS falls under this category. Endometrial changes or a pathology, for example, endometriosis, iatrogenic causes, for example, medications, and then N is for not otherwise classified, which is sort of a catch-all for some really rare diagnoses. And thinking through just sort of, the hypothalamic pituitary gonadal axis here, this is really the cause of a lot of cases of ovulatory dysfunction, which falls under that coin mnemonic, the non-structural causes here that we see. So just to kind of run through based on anatomy, hypothalamic amenorrhea can be caused by things like chronic stress, eating disorders, or high levels of exercise. And then we have pituitary causes, for example, Sheehan's, which is where there's pituitary damage after like postpartum hemorrhage, resulting in blood loss to the pituitary gland. And then reasons for increased levels of prolactinemia. So, for example, certain medications like antipsychotics, chronic kidney disease, especially if it's bad enough to require dialysis. And then prolactinomas are a rare, but something that we don't want to miss, rare diagnosis. And then with the ovaries, we can have PMOS, primary ovarian insufficiency, and menopause. And then within the uterus itself, these are going to be more sort of structural causes, but there can be scarring from prior instrumentation, leading to a lack of bleeding, a lack of menstruation. And then there can be anatomic obstruction in the vagina as well. This is much more uncommon, but this is why it's always important to do a pelvic exam as part of the workup for abnormal bleeding. And then other abnormalities that we will commonly test for, thyroid abnormalities, both hypo and hyperthyroidism can contribute to abnormal bleeding. And then really rarely, again, non-classic congenital adrenal hyperplasia, which is why we send off the 17-hydroxyprogesterone lab test when we're working up oligo or amenorrhea. So key point here, thinking about evaluation of abnormal uterine bleeding, some general principles here. Of course, we always want to check a pregnancy test, really low threshold to do this, and then consider STI testing if indicated. Some other things here. So thinking about if someone is having heavy or more frequent bleeding, the tests that might be most helpful here are going to be TSH, thinking about a bleeding disorder workup, things like von Willebrand factor, PMOS workup. Sometimes patients with PMOS can actually have this pattern of bleeding. It's much less common, but it can happen. And then CBC or iron studies to look for sequelae of the heavy bleeding. And then less frequent or no bleeding, so oligomenorrhea or amenorrhea. Again, checking a TSH, checking a prolactin level, considering FSH and estradiol if we are concerned about primary ovarian insufficiency. So for example, patient is 39 and 40 years old, has hot flashes, difficulty sleeping, is also noticing that their periods are becoming more and more spaced apart. This is a reason to order FSH and estradiol. The expected pattern of these labs would be high FSH and low estradiol here. Reviewing the medication list, so hormonal contraception is a very common culprit for abnormal bleeding, and sometimes there's just some management that we can do there. For example, if they're taking continuous birth control pills, they might just consider taking it cyclically, so taking that 1 week of placebo pills to sort of let the endometrium reset for 1 or 2 months and then go back to continuous use. Certain medications like some of the antipsychotic medications like risperidone interfere with the dopamine prolactin pathway and cause prolactinemia. Anticoagulation, again, for patients especially who are taking rivaroxaban or warfarin, high risk of having heavy bleeding there. And then medications like tamoxifen also increase the risk of endometrial cancer and hyperplasia, as I mentioned. Some of the exams and studies, so pelvic exam always indicated for abnormal uterine bleeding, and then just making sure that patients are up to date on their cervical cancer screening, also important. I have a really low threshold to get a pelvic ultrasound just to make sure that we're not also dealing with any structural causes. You might already have a diagnosis of some sort of ovulatory dysfunction, but there might also be additional structural causes that could be taken under consideration. And then endometrial biopsy if indicated as well. General principles for management of abnormal bleeding. So with heavy menstrual bleeding, high-dose NSAIDs is actually one of the first-line treatments. It doesn't necessarily get at the underlying cause, but what it does is it interrupts the prostaglandin cycle, decreases levels of prostaglandins, which then leads to decrease in inflammation and some vasoconstriction as well at high doses. And then progesterone-based hormonal contraceptive options such as oral pills or the IUD or Depo-Provera shots can also help with heavy menstrual bleeding. For a lot of people who use Depo will actually become amenorrheic. Combine oral contraceptives as long as they don't have contraindications to estrogen. Tranexamic acid is another option here, although in clinical practice is really not used very widely, but it is an option. And then procedural surgical intervention. So for example, especially if patient has done family planning and is developing iron deficiency anemia, just recurrently, maybe an option here is actually hysterectomy. For oligo or amenorrhea, the goal is really to treat the underlying cause, especially because, as I mentioned earlier, a lot of the causes are along that HPO axis. So if POI, just remember that we're using full replacement dose of estrogen and progesterone. And then if functional hypothalamic amenorrhea, goal is for lifestyle changes, so trying to increase calories and improve nutrition, trying to decrease exercise, and then also considering estrogen and progesterone. There's been a shift away from using oral contraceptives exclusively and really trying to use transdermal estrogen and oral progesterone. And the reason for that is because it seems like the ethinyl estradiol that's used in oral contraceptive medications may not actually be beneficial for bone health, whereas transdermal estradiol actually is. So again, this is something that's newer overall, so I don't know that it would be tested on, but just something to know that for people with functional hypothalamic amenorrhea, we want to make sure we're treating their higher risk of decreased bone density in addition to cardiovascular disease risk. Okay, so moving on to preconception care and chronic disease and pregnancy as our next topic. We have a case here again, 34-year-old G2P1 woman with a history of type 1 diabetes, presents for preconception counseling. Her last A1C was 8.2. Her previous pregnancy was complicated by fetal macrosomia, which is just increased birth weight, and shoulder dystocia. She is currently taking insulin, glargine, and Lispro. Which of the following is the most significant maternal risk if she becomes pregnant now? Okay, great. So we have preeclampsia and also placenta previa. So and also hyperemesis gravidarum. So the sort of point of that I was trying to make with this question here is thinking about what does a history of pregestational diabetes put someone at risk of with pregnancy. And preeclampsia is the answer here. None of the other conditions here are associated with pregestational diabetes. So really important to think about management of medical diseases prior to pregnancies, and especially diabetes, pregestational diabetes, especially if a patient has hyperglycemia around the time of conception, is associated with both increased maternal and fetal risks. And that includes an increased risk of preeclampsia because of underlying vascular dysfunction, worsening retinopathy, nephropathy, or hypertensive disorders of pregnancy, and then increased risk of C-section delivery as well, especially because of higher birth weight for baby. Some of the fetal risks of hyperglycemia include congenital malformations, so cardiac neural tube, cleft palate, limb defects, and then polyhydramnios and preterm labor delivery, and also increased birth weight, and then respiratory distress syndrome. These are just a couple of the things. So if possible, we want to try to target really tight glucose control around the time of conception and throughout pregnancy. A target A1C of less than 6.5 is what's recommended by ACC-AHA, American Diabetes Association as well. And um, next case here. So 28-year-old woman at 9 weeks gestation presents for a prenatal visit, diagnosed with hypothyroidism 2 years ago and takes levothyroxine 75 micrograms daily. TSH prior to pregnancy was 1.8. Today it's 4.9. She feels well and denies symptoms of hypothyroidism. Which of the following is the most appropriate management? Okay, great. No issues here. Everyone is on board that with pregnancy, there is an increased need for thyroid hormone supplementation. And so we would want to increase the levothyroxine dose by 25 to 30% with a target of less than 2.5, especially in the first trimester. This is for a couple different reasons. So baby completely relies on maternal thyroid hormone, especially during the first 10 weeks of development. And if that's not present, then that can lead to congenital issues there. And then there's also just increased blood volume, increased thyroglobulin binding as well. So we want to make sure that once we know that a patient is pregnant, that we're increasing their dose of levothyroxine and monitoring with this target of less than 2.5 as well for TSH. Next case here, 36-year-old woman with hypertension and diabetes, here for blood pressure follow-up, hopes to become pregnant and would like to stop her oral contraceptive. Does not smoke, drink, or use drugs. Medications are combined oral contraceptive, lisinopril, metformin, sertraline, and acetaminophen as needed. No notable exam findings. You recommend starting a folic acid supplement and also recommend stopping which of the following medications? Great. Okay, so we have both lisinopril and sertraline and metformin here as answers. And the answer here, we want to stop lisinopril. ACE inhibitors are contraindicated in pregnancy because they are teratogenic medications. Metformin is actually okay to continue in pregnancy. Generally, so especially if someone's already on it, you could consider continuing it, would work with OB on that, but both metformin and insulin are okay. And SSRIs in general, especially sertraline, are thought to be safe in pregnancy. And here we're really weighing the risk of discontinuing the sertraline and worsening mood disorder, worsening depression, anxiety, with the really, really low risk of being on the medication itself. So of course, with a lot of OB data, there's not very robust information, but generally it's thought that sertraline is actually relatively safe to continue throughout pregnancy for both mom and baby. Tylenol also considered to be safe with pregnancy here. This is just a slide that might be helpful reference as you're thinking about medications that are safe to use in pregnancy or medications that we want to try to avoid. A lot of these are going to be cardiac medications. Took this from from an ACC publication earlier this year. So thinking about managing hypertension in pregnancy, we want to rely first on nifedipine, calcium channel blocker, and labetalol specifically as a beta blocker. Amlodipine actually is also okay to use. Typically, that's sort of second line. Some of the other beta blockers are also okay to use. And even thiazides are thought to be okay to use if, for whatever reason, the first line therapy is not enough. I want to highlight here that one beta blocker that should be avoided is atenolol. This one is associated with some fetal growth restriction and low birth weight as well. Additional medications. So other medications that are safe to use in pregnancy, as I mentioned, metformin and insulin is okay. SSRIs in general, especially sertraline is the preferred medication there, and then acetaminophen. Medications to avoid in pregnancy, NSAIDs, especially after 20 weeks of gestation. Medications like warfarin, some of our other antipsychotic or mood stabilizer medications like valproic acid, lithium, and then medications like Accutane, retinoids, etc. Those are some of the more common medications to pay attention to here. Okay, so moving on to our next topic, we're zooming through all of this. Pregnancy-associated cardiovascular disease risks. Our case is a 45-year-old woman with a past medical history notable for gestational diabetes and preeclampsia. She's otherwise healthy with no history of tobacco use. Exam findings, blood pressure was 122/80, BMI was 27, and lab results from 2 years ago show an A1C of 5.2 and a normal lipid panel. Her Prevent ASCVD 10-year risk score is 0.9%, and in addition to standard recommendations regarding healthy lifestyle, what else do you recommend today? Okay. So we have all the answers have been selected except for B here. The answer here is going to be A1C and lipid panel at least every 2 years. And so let's talk through this a little bit more here. Statin use for cardiovascular risk reduction just with her Prevent ASCVD risk score right now, even though she has this additional risk modifier of preeclampsia and gestational diabetes. I don't know that I would necessarily start it quite yet. Coronary, we don't need to talk about the CAC score. No one selected that. A1C and lipid panel at least every 2 years. We'll talk through the guidelines here, but because of her history of gestational diabetes specifically, we're going to have more aggressive diabetes screening for her, especially 20 years after pregnancy when she is at highest risk of developing diabetes. Daily aspirin use, aspirin is overall, we're just really using it for a lot less in terms of primary prevention. In this case, this patient is not currently pregnant, does not have preeclampsia. There's not really a reason to start using daily aspirin now. And no additional recommendations. Again, I would be a little bit more aggressive about managing cardiovascular disease risk here, given her pregnancy history. So some of the key points here, history of gestational diabetes, history of gestational hypertension, and of preeclampsia are all independent risk factors for cardiovascular disease. And these are things that are not actually taken into account when we are using risk calculators like the Prevent score or the pooled cohort equation. So it's important for us to also ask about this clinically when we're talking with our patients. With a history of preeclampsia, there's a 2-fold higher risk of future cardiovascular disease. And with gestational diabetes, 35 to 60% likelihood of developing type 2 diabetes within 10 to 20 years after that. So that's why we really want to be more aggressive about screening. American Diabetes Association and now the ACC have recommendations for checking A1C, lipid panel at least every 2 years for these patients. Okay, so just to really quickly sort of think about this 4th trimester. So after delivery, a lot of patients, will start seeing their PCP again more exclusively. So really thinking about some of the mood changes that can happen after delivery. So thinking about postpartum depression using the Edinburgh postnatal depression scale to screen for that, or just using PHQ-9 at least. Monitoring blood pressure and using medications that are safe in with lactation, which are listed in that chart that I presented earlier as well. Asking about any pregnancy complications. This is something that I think I personally forget to do a lot. And as we talked about earlier, there are some major increases in cardiovascular disease risk and diabetes risk if there is a history of gestational diabetes or hypertensive disease of pregnancy. So this is something that I'm, adding to my cardiovascular disease risk assessment more consistently. And then supporting lactation. Lactation has significant health benefits for both baby and for mom, reduction in the risk of cardiovascular disease and of breast cancer. And so, especially if patients are feeling motivated to breastfeed, this is something that I would want to make sure that we know who they can reach out to for lactation consultation, things like that. And then, of course, considering contraception. Birth spacing is important for especially for maternal health and just making sure that patients are sort of empowered with their own family planning choices here. Okay, so a case about contraception. We have a 37-year-old woman here to discuss contraception options. She is married and has a 1-year-old child, says that her child was a surprise because she had a hard time remembering to take her combined OCP. Periods are regular, heavy, and she does get cramping with her periods. Currently smokes a pack of cigarettes daily, and urine pregnancy test was negative in clinic today. Which of the following is the most appropriate contraceptive option for this patient? Great. We have lots of proponents of the IUD here for this patient, and I would agree here. Um, this was not a hard question. This patient is over the age of 35, is smoking a pack of cigarettes daily, so about 20 cigarettes a day. Those two things are together a contraindication for using estrogen because of the increased cardiovascular disease risk. Copper IUD is probably going to make her periods worse, more uncomfortable, heavier bleeding. And then the progesterone only pill, we're going to avoid here because she already has shared that she has difficulty with daily adherence. So some of the contraindications for estrogen, as we mentioned earlier, 35 and older, smoking greater than 15 cigarettes a day is a contraindication. Migraines with aura, history of CAD, vascular disease, or history of clotting or clotting disorders. If they have pretty advanced diabetes with known microvascular disease or other complications, it might be a reason to hold off on using estrogen-based methods, again, because they might be at increased risk of clotting or progression of their microvascular disease. Uncontrolled hypertension. So for someone who has, systolics in the 130s, 140s, who's taking blood pressure medications, I would feel okay with a discussion about using these medications, but especially if systolics is greater than 160, they're not taking medications, I would hesitate to use an estrogen-based contraception. Decompensated cirrhosis, again, is associated with an increased risk of clotting. CKD, especially if due to nephrotic syndrome, hemodialysis, or they're getting some sort of dialysis, again, increased risk of clot. And then, of course, if they have any sort of hormonal breast cancer or other types of hormonal cancers, we'll want to make sure that we're avoiding exogenous hormones here. All right, so moving on to our next topic, which is breast symptoms. Our case, we have a 28-year-old nulliparous woman with no significant past medical history who's evaluated for a right breast lump. No history of breast trauma or nipple discharge or axillary lymphadenopathy. She's taking a combined oral contraceptive. Her mother had breast cancer at 65 years old. On exam, there's a firm 3 centimeter non-tender, well-circumscribed mobile mass at 2 o'clock, 4 centimeters from the nipple with no lymphadenopathy noted. Which of the following is the most appropriate diagnostic workup for this patient? Okay, great. So we've got a couple of votes for B and for D here. So the answer is going to be B. So when we're thinking about diagnostic breast imaging, we decide which test to order based on the age of the patient. And that's just because we know that mammograms are unfortunately not as high yield in younger people with more dense breast tissue. Most young people will have dense breast tissue. And because also for people who are younger, there's just a lower suspicion overall for cancer. So we really rely on either ultrasound alone for those who are younger or mammogram with ultrasound for those who are older. And we'll talk through that here. So first point I want to make here is just thinking through the difference between screening and diagnostic breast imaging. So when we're thinking about screening guidelines, this is just applicable for thinking about routine breast cancer screening. If a patient presents with any sort of breast symptoms, breast concerns, this is where we're actually switching topics and moving away from screening and actually doing diagnostic breast imaging. And there are different guidelines for this. So as I mentioned earlier, for those under the age of 30, the agreement here is that we are relying on breast ultrasound only for diagnostic imaging. For those who are above the age of 30, who are 30 or older, and that recommendation kind of varies for some organizations. It's 30 and older. For others, it's 40 and older. Again, I don't think that'll come up on the exam, but know that for 30 and older, we say diagnostic mammogram and a breast ultrasound used together for diagnostic workup of a palpable finding. I also want to emphasize here that many patients, in fact, most patients will experience bilateral cyclic breast pain with their menstrual cycles at some point in their life. So this is, pain that comes on maybe a week before the period, maybe for the first couple of days of the period. It's really bilateral, it's diffuse, and then things resolve on their own. And that happens, with each period. Compared to non-cyclic breast pain or focal breast pain, if patients have focal breast pain, that can be considered what we call a lump equivalent, meaning you could consider just going ahead and recommending diagnostic imaging to work this up, especially if it's non-cyclic pain that you're dealing with, that's focal and unilateral. We want to make sure that we're ruling out any sort of concerning pathology there. Some of the more benign causes of focal pain would be, for example, trauma. Trauma can lead to fat necrosis in the breast, and that often feels like a painful lump. There can be cysts that kind of come and go that become more symptomatic, especially around the time of periods, but not always. Other pathology like ductal ectasia, which is just dilation of the ducts due to some inflammation prior breastfeeding, things like that. Mastitis, typically this is a pretty obvious diagnosis coming along with typical infectious disease symptoms, fever, chills, redness, swelling of the breast, maybe some discharge noted as well, etc. Okay, and then lastly here, we're going to wrap up with a case about menopause, or there might be two cases here. So we have a 58-year-old woman with severe vaginal itching and discomfort, progressively worse in the past 4 months. No discharge or odor noted. Intercourse is also painful despite lubricant use as needed. Last menstrual period was at 52 years old, and she does not currently have any hot flashes or night sweats. Exam revealed dry vaginal mucosa that is smooth and shiny. Blood vessels are visible beneath pale mucosa, and there's some scant bleeding with speculum placement. There's no masses or growths noted on the cervix or in the vaginal canal. Vaginal pH is 6.0. Wet mount shows occasional leukocytes. Whiff test is negative, and there are no clue cells and no hyphae on potassium hydroxide preparation. What would you recommend for management of her symptoms? Okay, so we have votes for both D and E here. I would say here that this patient, probably her symptoms are due to the genitourinary syndrome of menopause due to low estrogen. So working this up here, likely doesn't need systemic menopausal hormone therapy because she does not have these vasomotor symptoms, and it's really sort of localized symptoms that she's dealing with. Oral or topical metronidazole, that's getting at treating bacterial vaginosis, which, she doesn't have clue cells on her exam. Although her vaginal pH is higher, that is also the case for postmenopausal vaginal canal. Oral fluconazole, so that's treating a yeast infection, which, with severe vaginal itching and discomfort, that does sound like yeast infection, but just especially given the exam findings, there's no change. There's no thick, white, cheesy discharge on exam, and there's no hyphae and potassium hydroxide preparation. I would say this is less likely. So I would consider low-dose topical vaginal estrogen here. So genitourinary syndrome of menopause, symptoms will typically start a few years after menopause and typically also, unfortunately, worsen with time, which is the opposite of vasomotor symptoms. For a lot of people, the symptoms are worse around the time of menopause, and then they kind of start to taper off over time after that. So with GSM, there's an increased risk of UTIs. There's vaginal dryness, irritation, pain with sex, and sometimes patients can also notice what they will describe as spotting, or maybe there's some scant bleeding when they're using toilet paper to wipe. And this is why an exam is really helpful. If you're seeing that there's just some skin that looks like it's irritated or mucosa that's irritated there, then you might be less concerned for something like endometrial hyperplasia or cancer. Low-dose topical vaginal estrogen is a safe option for almost everyone. A lot of oncologists feel comfortable prescribing low-dose vaginal estrogen for patients, after breast cancer treatment, because there's so little that's thought to be systemically absorbed. So I would still run it by oncology, but this is generally thought to be safe. And there are also non-hormonal adjunctive medications that can be, or therapies that can be used. So for example, over-the-counter vaginal moisturizers, and then also as needle lubricants for intercourse. And just a note with the moisturizers, those are things that are used more consistently every day if possible. Just like a moisturizer anywhere else on the skin, it's more effective with more consistent use. And our very last case here, 52-year-old woman comes to see you for help with 6-month history of worsening hot flashes and night sweats, has had to leave 2 work meetings in the past month due to symptoms. Last menstrual period was 10 months ago. There's no personal or family history of cancers, and exam was unremarkable. And her prevent 10-year ASCVD risk was calculated to be 1.5%. What is the most appropriate management for this patient's hot flashes? Okay, so we have most have opted for A, but some for B and C as well. So let's talk through this again. So a couple things to highlight here. I would recommend menopausal hormone therapy with estrogen and progesterone for this patient. This is the most effective method for managing vasomotor symptoms, and this patient is obviously very affected by these vasomotor symptoms. Menopausal hormone therapy with estrogen alone is not recommended for patients who have a uterus. So there's no prior medical history here to suggest that she has had a hysterectomy, in which case we would not be recommending estrogen use alone. Low-dose topical vaginal estrogen is not going to treat her main symptoms of vasomotor symptoms, since so little, if any, is systemically absorbed. So again, this is really used for genitourinary syndrome and menopause, increased UTIs, irritation of the vagina or the vulva, things like that. Progesterone alone, again, will not treat her main symptoms. This is something that is clinically becoming more and more popular for things like insomnia, for example, but probably is not going to help her hot flashes and night sweats unless it's used at very, very high doses, which right now there's really no good evidence to say that that's safe at this time. This is not something that I would expect to be, a right answer on the board exam. And then lastly, the combined oral contraceptive pill could be an option here, but I would say that the best option here is menopausal hormone therapy, because that's going to be a lower dose of hormones compared to the COCP. Menopausal hormone therapy is somewhere between 10 to 20% of the hormonal dose of combined oral contraceptives. So I would really opt for MHT instead. And key point here is that generally, we want to try to initiate menopausal hormone therapy under the age of 60 and within 10 years of menopause. And this is due to something called the timing hypothesis, which is just that as we age, we have a higher risk of cardiovascular disease. And there were some studies that suggested that those who started taking menopausal hormone therapy after the age of 60, when maybe there had already been some endothelial dysfunction, some vascular damage, that was associated with an increased risk of cardiovascular disease. I will say in practice and in like current research, this might all be changing, but I think for the boards, this is probably a safe answer. With increased years of use, there's also an increased risk of breast cancer, unfortunately. However, the risk isn't going to increase by like 3-4 times, similar to what we see with atypical findings, for example, or with BRCA mutations. The relative risk increase here is maybe 1.5, maybe up to 2 times, and typically for the time that they're taking it, and maybe for a couple years afterwards. So even though there is an increased risk of breast cancer, it's not necessarily an absolute contraindication. At the same time, I think for the boards, probably if there was a patient who had an increased risk of breast cancer, most likely they're going to want to see that you're not going to choose to prescribe systemic hormone therapy there. I'm guessing there. So that might be a little bit more nuanced. Of course, if there's a personal history of hormonal breast cancer, if there's an ASCVD risk of 10% or higher, and then if there's a history of stroke or VTE, these are all reasons not to prescribe systemic menopausal hormone therapy. However, different from OCPs, from combined OCPs, migraines, even with aura, okay to use menopausal hormone therapy. And then lastly, USPSTF grade D recommendation that MHT should not be used for primary prevention of chronic disease. And so just to sort of present the management options here, if there is a uterus, we need to use progesterone with the estrogen. And typically the sort of go-to here is transdermal estradiol with oral micronized progesterone. And the progesterone, again, is protecting against unopposed estrogen exposure. And then there's also a medication called basidoxifene that is a SERM plus estrogen, thought to maybe have fewer sort of side effects compared to some of the other medications, but also can be really expensive, hard to get insurance to cover this medication right now. Without a uterus, patients can use estrogen alone pretty safely, especially from like a breast cancer standpoint, for example. And then there are non-estrogen alternatives, for example, gabapentin, really helpful for patients who are also having insomnia. If they're taking gabapentin at night, that can be helpful to get them to sleep and also helpful for their night sweats, hot flashes. SNRIs, SSRIs, also on the list. And then there's these new neurokinin 3 receptor antagonists like fezolinetant or Veozah is the brand name. These are a great option for patients who have a history of breast cancer who may not be able to use estrogen and progesterone together. And that's it from me. Thank you, everyone, and good luck with your board exam. And thanks again to Addie McClintock and Eliza Sutton for this presentation. And if you have time, please fill out this feedback for me.